Thank you, and welcome to those who are attending this. This is a follow-up to our in-person event that we held at the United Way Center last week. So some of you I see are repeating, and others are here for the first time. So again, welcome to our session here. I don't know who's operating the deck, but if we can go to the next slide, I will have 4 or 5 minutes of introductory remarks. So this is the joint effort of the Houston Business Coalition on Health, Texas employers Texas employers, PHSO, Population Health Services organizations, and our partner starting off in this effort, XO Health. So you're going to hear from all three organizations in the first half hour, and then we'll save the rest for questions. So let's go to the next slide. So those of you who know me know I'm passionate about this and passionate about employers' funding of healthcare as much as I am about their employees who have to use it. What this particular slide shows is some information that you may not be hearing from other sources, but it's representative of Houston. So what this shows in the middle column here is two hospitals from the Houston market. We have four major health systems here, each with 4 to 8 different hospitals. All of them charge a percentage of Medicare to employers. This information is from the RAND Hospital Price Transparency Project. This information can be found on our website if you're interested in a little bit more depth on this. But this serves as an example. And what we show are two hospitals, one charging employers 336% of Medicare, the other 318. One of the points here is that what employers are charged is not directly related to quality. Those of you who may be familiar with the Leapfrog Group and its safety grade ratings and safety survey shows that these particular hospital, one was a C, one was an A. What's not shown on this, and again, we have this on our website, we have this for every hospital in the market. We show this information as well as the CMS star ratings. The CMS star rating for location 1 is a 2. The CMS rating for location number 2 is a 4. So the point is there's not a correlation between price and quality. The other point that I would make is that Houston employers have long been told that they need to pay more for hospital services, both inpatient and outpatient, because of a shortfall from other payer sources. Think Medicaid, Medicare, Medicare Advantage, uninsured, charity care, et cetera. The data that the hospitals provide would indicate maybe that's not entirely true. What the on the left-hand column, what we show here is for these two particular hospitals, what it would take employers to pay for that hospital to break even. And we're not saying they should break even. We're not saying what their profit margins should be. But we do think that there's a big enough gap that with a collective effort, we should be able to negotiate better prices. What this shows for Hospital 1 is the break even. And what that is, again, for the operations to pay for commercial, Medicare, Medicare Advantage, Medicaid, uninsured, charity care, it's 125% of Medicare. Location 2 is 190%. The other column here, commercial profit margin, and again, this is on our another website, Texas Employers for Affordable Healthcare. And we have this for every hospital in the state of Texas, but you can look at it by region, would be glad to direct folks to there and help them navigate at another time. But what we know is that in aggregate in Texas, hospitals make about 20% profit margin on Medicaid. They're not losing money on Medicaid in aggregate, in median. Median price for Medicare is about a 4% profit margin, about a 7% profit margin on Medicare Advantage. And then, of course, the commercial payers it's an operating profit margin of 45 and 55% here. So we're just showing that as an example to hopefully make you aware that, quite frankly, employers are overpaying for healthcare, and we think collectively, and it has to be collectively, we could negotiate better deals. The other, or the last thing I would say here is it's all about NPS scores, and this is for health plans. You can see that it's about a 25. So again, maybe folks aren't just totally in love with their health plan. So we just provide this to create a sense of opportunity and hopefully make a case that collectively we can do better than we're doing. So I appreciate that opportunity. I think Ken, you are next up, if I'm not mistaken.
Yes, thanks, Chris.
Maybe not. Next slide. Maybe not.
Yeah.
No,
that is
quickly
you, Chris.
here.
Sorry.
I'll just say that we've been working on this for a long time. Houston Business Coalition on Health, through educational programming, creating awareness. I just hopefully created some awareness there. We also have created a C4 legislative policy organization, Texas Employers for Affordable Health Care. We were successful in the last session getting legislation passed to prohibit anti-competitive language between hospitals and health plans. We'll be coming out with a guidance document for employers to demonstrate how they can take advantage of this. This year, we created the Texas PHSO. We've been working on the smart network in various forms for a few years now. What's different now is we have a partner and we have funding to make this happen. So the rest will be relegated to our partners that will be speaking, the PHSO and and XO Health. So I appreciate your attention.
Next slide, Sam. So hello, everyone. I'm Ken Yonda. I am contracted with through my consulting agency, Wild Blue Health Solutions, but collectively between me and my organization and Supra Hospital, who you all see on the video as well, we are essentially the people that are standing up the Texas Employers Population Health Services Organization, or PHSO, as we call it. So we're kind of the development management team of that. And as we've been talking to employers, primarily through the Houston Business Coalition on Health, but the PHSO is a separate entity from Houston Business Coalition on Health. So other employers who are not members of HBCH can join us. What we keep hearing from employers, and we're trying to build something for employers by employer, that, as Chris said, people are not really that enamored with their current health plans. As a recovering health plan executive myself, I appreciate that, and perhaps unintentionally contributed to some of that low scores for health plans. But they're not getting it done in terms of what we feel is really necessary. You add that to the consolidation that's going on in the marketplace, not just of the hospitals, but the vertical consolidation that's going on with the hospitals buying up doctors' practices, things that are going on in the pharmaceutical industry and stuff. There's just a lot of things that are not going the right direction in healthcare right now, as I think about it, in terms of the healthcare triple aim. How do we improve outcomes? How do we improve customer satisfaction and lower per capita costs at the same time? And even though there's lots of point solutions out there, the innovation just feels like it's kind of stagnant right now. So it's not going to get better unless we have an opportunity to bring together employers to do something differently about it. And as Chris mentioned, we feel like we can do some direct activities as a coalition, if you will, of employers working together rather than each individual employer trying to attack these by themselves. So next slide, Sam. So really what we think of is the first thing that we want to launch through the PHSO is or what we refer to as our smart network, where we're taking physicians and building on advanced primary care to make sure that they're integrating behavioral health services into primary care rather than a separate carve out, that there are referrals to high quality specialists, and that those specialists are increasingly paid, moving away from fee-for-service to value-based payment models and specifically episodes and bundle type payments. We want to contract with high-value facilities that are willing to have straightforward, transparent provider contracts. As having negotiated some of those hospital contracts between big insurance companies in the past, I can tell you that it's not just a straight 316% of Medicare, as Chris, sort of. It's some services are at 250 and some are at 500, and there's just all kinds of carve outs and things that result in those payments. And so we're trying to do something that is, we don't want hospitals to go bankrupt, but we think that there's great opportunities for us to negotiate better agreements with them. And there are, some hospitals that seem to be recognizing that they need to do business a little bit differently. So we hope that we can generate better outcomes and better experience for members and save money by direct contracting, by doing population-based payments, but also some of that savings has to come through with a more transparent PBM relationship, and really having alignment between, from the physician to the patient to the payer, that there be an alignment of things. And so we think these are sort of the important characteristics of the smart network, and we're in the process of building that network as we speak. We're having lots of great conversations, getting letters of intent signed, close to some significant contracts that were announced, but we're hoping that we can launch this by January 1 of 2025. One more slide, Sam, for me. And the way we're thinking about doing this is that the PHSO is, we're focused on our side right now on the building the network, but we need an administrative partner to work with us to be able to do all of the systems configuration, to pay the claims, to have the provider databases and all those kinds of things that you need behind the scenes. And so we had talked to a number of potential TPA partners and stuff, and really have been very encouraged by the relationship that we've been developing with XO Health. And part of that, frankly, is XO's philosophy about this is very much aligned with us in terms of where we're trying to go, in terms of changing the way healthcare is delivered and paid for, and having that integrated experience rather than the fragmented experience. And so we're partnering with XO Health to bring this product to the market, where you can basically offer the smart network on an EPO or PPO basis, a tiered PPO basis, or an EPO basis as an alternate to your current plan design, and get a lot of additional value in this, with focus on improved satisfaction scores as well. We recognize some employers may not be ready to make that full jump, and so we're also looking at ways that we could take the smart network and position it with an existing TPA. We don't think you get all the same benefits, frankly, of doing that, but if some employers want to talk to us about that, we're willing to talk about option 2. But we're really excited about the relationship with XO, and we've been working with them for about 6 months now, and it actually, I think sometimes we sort of forget who's working for who here because it's really a partnership type of thing. With that, I think I pass it back to Salem now.
Ken, thank you. Yes, and it truly is a partnership, and good day to everyone. Salem Shinar with XO Health, the Chief Commercial Officer, and just really quickly, just to share with you all who is XO Health, what are we about? We do enjoy a fantastic partnership with Ken and Chris and the team, the Houston-based team. We are a full-service health plan launching January 1st, 2025, serving self-funded employers. And we're launching in 3 primary markets, Houston being one of them, the other 2 being Dallas and Atlanta. And what that means is that's where we will be working to develop directly contracted provider networks, such as the Smart Network in concert with Ken and the team, and other networks across the other 2 markets, which I mentioned. But this notion that a health plan that can do better, Chris mentioned NPS, which is abysmal for most health plans today. They've really lost sight of who they serve. We're only serving self-funded plans. We don't have the conflicted interests of serving Medicare, Medicaid members or beneficiaries. So all of our investment is going towards serving self-funded employers. Obviously, being new, we have the benefit of being able to utilize a tech stack which doesn't have any debt, in the sense that it doesn't require any integration with any legacy tech systems. We really can utilize the full scope of the tech which we are partnering with and building ourselves and integrating in order to serve our customers. We're really excited about that because the word no just really doesn't seem to come up in our vocabulary very often when we think about things that our customers are asking of us. I'll save the network discussion for Darla, who will be speaking right after me, to talk about our partnership to build out the Smart Network and to offer it to Houston-based employers or other employers that have employees in Houston. But the real notion here that we're trying to drive to is this notion of shared accountability with providers, that we are working with providers and aligning ourselves with providers that really are interested in practicing at the top of their license, but are also who are willing to assume some level of risk for delivering both the quality and cost outcomes that our customers are looking for. As Ken said, we are a full service full service health plan. We'll be offering, in addition to the Smart Network, we'll be offering our advocacy and navigation services, which will help drive our members into the Smart Network and the ideal networks, but it also will be there to serve members' needs beyond just getting them to the right provider, because we know there are a lot of social needs that are unmet today, and we'll be focusing significantly on both health and social health risks. I think that's really what I wanted to share with all of you. We are going to be offering guarantees in the market in terms of financial guarantees. So beyond the Smart Network, the opportunity to place financial guarantees around cost of care savings or net promoter score, or otherwise, to be able to offer that into the market, into our customer base. So on the next slide, I think I'll just wrap really quickly by saying we are a full service plan. January 1st we launch. We'll have obviously medical, but also pharmacy, behavioral health, spending account administration, stop loss for those employers who need it or are interested in it. And I mentioned already that we'll have, the ability to we'll put significant financial fees at risk, as well as performance-based guarantees around our ability to serve a client and to serve them in a way that is differentiated and really getting at their needs. I'm going to pause here, turn it over to Darla in the interest of time, because I think that is really what we're here to hear about, is the Smart Network. So Darla?
Hi, thank you, Salem. I'm Darla McGahee. I'm Vice President of Network Development for XO Health, and I have accountability for building out the provider network across all of the XO Health markets, but specifically in Houston, and partnered closely with Kenyonda's team to build out the Houston provider network. Over the last several months, XO Health has been working tirelessly to begin laying the foundation for building the provider network. We've been focused on things like developing provider contract templates and provider manuals, as well as fleshing out our reimbursement strategy. Most recently, though, we've been developing our target list of providers so that we can get out in the field during the month of April and May and begin meeting with providers and contracting with them. Our network strategy is really a layered approach that includes the SMART network as well as a broad fee-for-service network. And we'll talk about that fee-for-service network first. The fee-for-service network has two elements. One is a competitively priced and directly contracted fee-for-service network that's paired with a carrier-owned lease network. And together, the two provide broad geographic access in the Houston MSA, but they also provide coverage outside the Houston MSA for people who live outside their employer's primary location, or for instance, college kids who live away from home. Then layered on top of that fee-for-service network is the SMART network, which consists of our key strategic partners. These are the providers that we've carefully selected after a deep review of their quality, cost, and claims data. To identify these strategic partners, we started by narrowing the list of specialties to those that represent 60% of an employer's overall spend. So this would include advanced primary care, women's health, cardiology, gastroenterology, oncology, and then finally orthopedics.
Let me just stop you for a second, Darla. I'm still seeing the previous slide. So Sam, can you see if you can advance?
There we go.
Okay, thanks.
Sorry. Then next, we used data sources such as RAND and Definitive Healthcare to identify independent physicians who are not owned by hospital systems, and they don't admit exclusively to high-cost hospitals, and they have the flexibility to really do what's in the best interest of their patients and not necessarily what's in the best interest of their employer. And then finally, we layered in quality and cost data from both Embold and Health Quorum to curate a list of 41 provider groups for the Houston MSA. Together, these 41 provider groups represent about 2,900 physicians, 600 of whom are PCPs. And then over the next month or so, as I mentioned before, we plan to get out in the field and meet with these provider groups and begin learning more about them. As we learn more about them, their capabilities and their interest in working within our SMART network structure, this list may narrow a little bit as we identify providers who meet our network strategy. It's important to note, though, that the SMART network is going to be a real balancing act, and the program's success depends on building volume with these key strategic partners. And to do that, we're going to have to work with employer groups to build a benefit structure that encourages the use of the SMART network providers so that we can build that sufficient volume for SMART network providers and make the contract structure beneficial to them. For 2025, our goal is to have at least 20% of costs captured in an alternative payment arrangement and an additional 20% captured within the SMART network so that their balance is being handled by the fee-for-service and the lease networks. But then beyond 2025, we plan to continue refining the network and ultimately deliver a network that progressively results in progressively larger amounts of spend going into the fee-for-service network and the APM network and the SMART network, such that by year 3, we can capture 75% of the eligible spend in the APM or SMART network. I think we're turning it back over to Salem.
Darla, thank you. And I know that was a lot in a short period of time. Just really quickly for any of you on the line that are, at all interested in exploring this further in terms of, what can the SMART network do potentially for you and your organization compared to the network you're utilizing today. We can certainly perform for you a relatively straightforward opportunity analysis to that end, to understand, again, what type of cost of care advantage or differential could be offered to you. And then we are also interested, and apologize, we're not serving dinner this evening. For those of you that see it on the line, we won't be hosting a dinner this evening, but we'll be glad to take any of you that you would like to have dinner with us. We're glad to take you to dinner at a time and place of your choosing. I'll pause there. Sam, let's advance to the last slide, please. And happy to take any questions from anyone on the line, or we can simply answer some of the questions that we see here. Any questions at all, feel free to come off mute, or feel free to put a question in the chat if you like.
Hey, Salem, this is Dan. I have a quick question. It's really for the benefit of the group. When with the middle of the year approaching, those of us that renewed January 1 will start making decisions sooner than we may like. So with that in mind, when will details be available about who is going to be participating in the smart network portion of this, not necessarily the fee-for-service side?
Yeah, I'm going to ask Darla to respond to the timing of when that will be ultimately determined, just by way of just making sure that we're clear. Like we will need to know in order to perform both disruption analysis as well as geo access reporting, and for you all to make a decision for sure and for certain. That won't say that that's the end of the contracting process necessarily, because we will be contracting throughout this year, and we can theoretically contract up until the end of this year, right? Potentially, to the extent that we need to for adequacy purposes or other purposes. But Darla, any update for us on timing of when we expect to have some more transparency into the smart network finalization?
Yep, thank you, Salem. So with respect to the network adequacy overall, one of the benefits of having that foundational network of a fee-for-service leased network is that we get instant network adequacy with a single signature. So we are literally a week or two away from finalizing the contract with our partner there. In the background, though, we continue to work on direct contracts with providers, both on a fee-for-service basis as well as the smart network. And you're right, we will continue to do that. Actually, we'll continue to do that through the end of 2024 and well beyond. We'll continue refining that network, as I mentioned, as we try to increase reliance on that APM and smart network and less reliance on the fee-for-service network over time. As far as when we project to have contracts completed with providers for the smart network and the APM, we are just getting out in the field now and beginning those conversations. There are some that are much further along. There's a couple with a very, very large groups that have a couple thousand providers apiece that are much further along than some of the individual small discussions that we have in place. But we kind of have our sights set on the end of the summer for having some of these conversations wrapped up, and should be able to give you a better picture then.
I would say that we also have some sort of core providers that we hope to be able to make announcements in May. But you're right, Dan. It's network development is one of those things that always takes longer than you think it will be, and we've had months of conversations with some folks and other folks who it just takes a while to get it done. So I think I feel very confident that we'll really have a good network, but I wish, quite honestly, that we were had more that we could announce today. But I'm not panicked at all about bringing in a really good core network of both primary care and some of the specialists that will pay on a more episodic type basis. We're having some good discussions on the OB side right now, for example, and other places that it's coming along. I know that's not a satisfactory answer, but it's the nature of the business, unfortunately. It's Darla and others on the call home.
But just to add to it, just for a little bit of clarity, like we do have the ability to perform an opportunity analysis today based on the types of on your claims, historical claims data, as against the bundled payments and episodes of care that we are going to be contracting for and what those bundles look like and what the PMPMs costs look like for both for chronic condition management as well. So we will have the ability to get pretty close to a more than a directionally correct estimate of estimated savings, without even having finalized what the network construct will be in terms of who's in and who's not. Just wanted to make that clear.
Thank you, guys.
Thanks, Dan. Any other questions?
Question here. We showed the slide earlier. Again, folks don't line up and say, God, I love my health plan. That just typically does not happen. You saw that with an NPS of 25. How was the 70 NPS determined for XO Health, given that you haven't launched yet?
Yeah, that's a great question, Chris. You know, the idea that we as consumers in our daily lives have experiences that are pretty reasonable when it comes to buying things and doing business with organizations. We can think about the ones that we use probably most regularly. I'm thinking of Amazon. I'm thinking of other electronic purchases or experiences that we have, digital purchases that we have experience with as consumers. We have seen some point solutions in the healthcare space as well that have enjoyed pretty good NPS in the 70s, 60s, 70s. So our goal is that we put something similar in the marketplace in the way of, and it's not just aspirational. We're going to be putting financial guarantees behind this, Chris. And it really speaks to the type of member and employer experience that we're really trying to drive here. As I said, in my comments earlier, employers have been relegated, particularly self-funded employers, have been relegated in many cases to second-class citizens of their health plans. And I'm not ashamed to say, I came from a BUCA. Our investments were really directed at other parts of our business other than our commercial self-funded employers, because they're, quite frankly, they're not growing at the pace that a Medicare or Medicaid population was growing. So that's where the investment dollars would go, and that's where a lot of the focus and attention would go. We think we can do better, substantially better in terms of focus on self-funded employers in terms of how we serve them, and then as well their employees' independence. This notion of an advocacy and navigation service, we see a lot of carve-out point solutions that are doing that today. We believe that service really is best suited to be embedded within the health plan for a lot of reasons, because you also have the ability to embed within that advocacy and navigation solution a provider services or a provider contact center as well that works really closely with the member services in case there are any provider issues or the need to help a member schedule an appointment with a contracted provider, which we will be able to help do. This notion of taking a lot of guesswork out of healthcare for a member, so that if they do need to access service and they do incur expenses, and they won't be getting a myriad of bills from providers, that we'll be able to consolidate billing for them in what we call our one bill process, so that members will get one bill, and they'll know what they should pay and when they should pay it versus has my insurance paid yet, et cetera, from an anesthesiologist or a facilities charge or a radiology charge, et cetera. So the idea of putting members and employers at the center of this health plan, while also making this a win-win for providers, because we really are trying to take the adversarial nature of provider contracting out of what we do with them and really try and make this a win-win-win between employers, providers, and members. So, Chris, that was a great question. I don't know if that got at some of what you were asking.
Another question that came up on Wednesday, nobody's asked it yet. Where's that 20% savings coming from? That's guaranteed.
Yep. We're going to take it from the rounding errors from your checkbook, Chris.
Yeah.
Just so you know, no, the savings are really, if we were focused properly on and Darla, I'll defer to you also, but if we're focused properly on the areas within the healthcare system and how we contract for services with providers where there is waste and inefficiency, which is really where we're focusing a lot of our contracting efforts, and allowing providers to practice at the top of their license by removing certain bureaucratic things that we make them do, like prior authorizations. In certain cases, we know prior auths are approved 95, 99% of the time, and it simply is added expense and bureaucracy for a provider. So to the extent that it makes sense to remove those types of bureaucratic processes for a provider, help them practice more, as I mentioned, at the top of their license. We believe that there are significant opportunities for savings in the way, and as well as just care coordination among providers, right? If a provider is coordinating care, whether it's a primary care provider that's helping to coordinate care and keep people out of from bad things happening at the hospitals or otherwise, that's really the name of the game, as we all know. And so our contracting efforts with providers are focused on that. Darla, I don't know if there's anything you wanted to add to that.
Yeah, I kind of touched on this a little bit in my discussion about how we selected our key strategic partners. But one of the things that I mentioned was that we selected providers who are independent and have the flexibility to alter site of care, as one example, and go to where it makes the most sense for their patients. So that's one area that we can address savings. Also, our payment model with providers really supports this concept of aligned incentives, where the providers can practice medicine and do what's in the best interest of their patients and not have to worry about those administrative burdens, as Salem mentioned, getting prior authorizations and so forth. But the payment model really supports their ability to do that. Is there anything else you'd like to add, Tammy?
Thank you for asking me. I'm sorry I'm not on camera. I'm outside my office today. I mean, actually, the straightforward answer is that the savings guarantees are made because we're willing to make them, right? I mean, and we're comfortable making them. And we're removing the mystery about that. We're comfortable making them for all of the reasons that Darla and Salem described, and that we will send all of you a follow-up FAQ to provide more detail about. The only other thing I would mention is that by sharing your historical claims data with us, what we will do with that information is we will group all of your historical claims into actual episodes of care that we would be making cost guarantees on. We'll look at each of those episodes, and there's about 200 of them across clinical medical conditions and surgical conditions and maternity. We'll put all of the claims into a bundle, and we'll actually examine what are the actual savings drivers out of all of the many things that we just listed by episode. Is it a site of care problem, which is really a pricing problem, or is it a lack of care coordination or gaps in care? We'll attribute all of the excess spending to as much of one of those categories as we can, so that we can be very strategic when we circle back with you with the results of that and help establish priorities.
Yeah. I was very pleased to hear Dr. Tony Lynn, who's the chairman of Kelsey-Seybold, and speak at the Greater Houston Partnership Luncheon about a month ago about fraud, waste, and abuse in the system, really on the backs of employers. He is going to elaborate a bit on this at our June 26th forum at Rice University. So that's a real plus to hear that from the providers. So just wanted to add that in there.
Thank you, Chris. Any other questions? I don't see anything in chat. Any other questions from anyone on the line? Okay. Well, on behalf of all of us, the Houston Business Coalition on Health, the Texas PHSO, XO Health, I'd like to thank you all for taking the time to join us today. If you have any questions as follow-up, or if you are interested in any type of opportunity analysis, please don't hesitate to reach out. And we hope you have a great rest of your day.